Hello, friends. So I'll be talking on this, not talking, I'll be discussing this case vignette. So this was discussed in one of the panel sessions in Delhi recently. So it's a very simple overview as to how to approach the abdominal pain, acute abdomen sort of a situation. So it's a fairly simple sort of a case scenario, but it's a good sort of an overview for us to have a little grasp on how to approach abdominal pain. So I'll just take you through the case. So this was a 70-year-old female with diabetes, hypertension, and coronary artery disease. So presents with recurrent abdominal pain of 1 week and has diarrhea and weight loss for 1 year. So the question that I would ask the panelist is, when someone comes to ICU with these complaints, so how would you approach this case and what are the differential diagnoses that one would have in mind? So here, if you look at it, so the reason possibly she's come to ICU is because of the recurrent abdominal pain, and now she's come with an acute sort of an abdominal diarrhea. But what one needs to bear in mind is the weight loss which has been prevailing for 1 year. So then the automatic question that would come is, what is the underlying problem that she could have as a weight loss? So obviously one thing that strikes is possibly a malignancy which may be high on the cards. But there is an entity called unintentional weight loss in most elderly. So 13% of the elderly tend to have unintentional weight loss, not necessarily with any sort of an organic disease on the background. And the definition of weight loss is 5% of loss of weight in 1 month or 10% of weight loss in 6 months. So that is when you would qualify someone as having weight loss, 5% in 1 month and 10% in 6 months. So when you look at the weight loss in elderly, so there are certain physiological causes which could be labeled as acute or chronic. When I say acute or chronic, so it could be progressive deconditioning due to the aging itself, or it could be due to the background conditions that may be leading to some sort of weight loss, or some overriding sort of an acute reason which may have caused the weight loss. Then, so not to undermine, there are psychological causes also in elderly which leads to unintentional weight loss. So depression and someone being bedbound and not getting adequately nourished also is cited as a reason for unintentional weight loss. And social isolation and social factors, because nowadays most families are nuclear, so there may not be caretakers for the elderly, and the nutrition also can get compromised. So these are all quite intuitive reasons, but very less often paid attention to as to possible reasons that can lead to weight loss. So there can be a lot of socio-psychological factors which may lead to weight loss, and not necessarily it has to be an organic cause or any sort of the conditions that you would have in mind. So now the second thing is, so obviously we have to split the symptomology into three. So she had acute abdominal pain with diarrhea with weight loss. So weight loss we did address. So what are the differential diagnoses of abdominal pain? So abdominal pain, I think most of the panelists, when I ask, they would say abdomen is like a Pandora's box. So there are multiple causes for abdominal pain. But for ICU trainees, you need to have some clarity. Most of the reasons will be confined to the structures within the abdomen. So abdominal pain diagnosis, you can divide into acute and chronic abdominal pain. So when you talk of abdominal structural causes, so simple esophagitis or peptic ulcer disease can be cause of abdominal pain, or it can be inflammatory bowel disease or colitis and ischemic bowel, because this is a 70-year-old lady with diabetes and coronary artery disease. So vascular sort of a compromise is a possibility, and ischemic gut is also one of the common cause. Or simple fecal impaction, because many of the elderly people can have fecal impaction with bowel obstruction. That itself can lead to abdominal pain and distress. And bowel obstructions due to, it can be due to any obstructive cause, or it can be pseudo obstruction. So that is also a common cause of abdominal pain and diarrhea in elderly. Or diverticulosis. So this is very common in the Western population. Even in our Indian subcontinent, it is not uncommon to have diverticulosis with diverticulitis as a cause of abdominal pain. So these are some of the causes confined to the gut. And pancreatitis obviously is one of the cause cause of abdominal pain. One needs to look at DKA. If someone, she's a diabetic, so you have to keep that also in mind. And if there is ascites due to any reason, peritonitis is a cause, or biliary colic or cholecystitis is another cause. Appendicitis is a cause, and even UTIs due to nephrolithiasis with renal calculi can present with abdominal pain. And non-abdominal causes, you can have MI, which are referred pain to the abdomen, especially the epigastric pain, can be due to MI, or even pneumonias can have atypical pneumonias, typically, can present with diarrhea and sometimes referred pain in the abdomen. So these are some of the non-abdominal causes of pain. So just for our trainees, just keep this picture in your mind. So any structure within the abdomen can lead to abdominal pain. So non-abdominal structures, it can be cardiac related or it can be lung related. So then the next question that I would ask the panelists is, so once you have these differentials running in your mind, so what are the relevant investigations and workup one needs to do? So for this question, so for all my ICU friends, so when possibly we were doing post-graduate medicine, so we were very restrictive about doing only very specific investigations, and we had to reason out other investigations that one would do. But in ICU, we may have to do a spectrum of investigations in an elderly who comes with this situation to ascertain the causes of abdominal pain. So we wouldn't say only do hemoglobin or only do amylase. So we have to do a series of investigations to ascertain, because abdomen is as I said, is a Pandora's box, and there can be multiple reasons. So the tests would encompass the routine blood counts and LFTs, KFTs. So you have to do complete blood count to look at any increase in the white cell count, which may be indicative of infection or inflammation. So if there is increased total count, one has to do a blood cultures to see if there is an underlying sepsis due to infective cause within the abdomen. And complete biochemistry is needed. So gone are the days where in ICU we would say, do only creatinine, do only blood urea, do only hemoglobin. So that is not the norm in intensive care. We expect, especially because ICU time is gold, we have to do at least these are considered very basic in ICU: biochemistry, complete chemistry, kidney function test and liver function test, and arterial blood gas also is needed to look at anion gap, to look at, because she has diarrhea, you have to look at anion gap, you have to look at delta gap to see whether there is a coexisting acidosis with alkalosis component. And lactate is needed to look at any infective process or gut ischemia. Lipase and amylase in abdominal pain to look for pancreatitis, and you need to look at urine analysis to look for any UTI. And coagulation profile, if there is a suspicion of underlying sepsis or if there is liver dysfunction and GI bleed, coax has to be done, because all these are deranged. So this particular slide typically depicts, these are the routine investigations we expect in any patient who comes to ICU who is sick enough. They would mandate these investigations, which will give you an overview as to the indicators or signals towards possible causes. So this is something which is useful for all trainees to keep in mind. In ICU, we don't go with do only potassium, do only sodium. So we expect these. And to this, I would even add the most often I keep telling that routine basic investigations will also include calcium levels, magnesium and phosphorus, because if calcium is very high in this lady, it would only indicate that it may be a surrogate marker of underlying malignancy. Or if phosphate is low, it may indicate the nutritional component of that deconditioning has happened, and so is the case with magnesium. So it's very important. All these are done as a baseline investigation. Then the question I would ask our panelists is, what sort of imaging one would consider in this? Would you do a chest abdominal X-ray in this patient? Because she came with abdominal pain, with diarrhea, with weight loss. Does abdominal X-ray has any bearing in this day and age? So the answer is yes, because the abdominal X-ray done for this patient showed this. So as you see, I would ask panelists, what does this show? So if you see, she has a very dilated bowel loops, and if you look very carefully, she has a gaseous cyst within the bowel wall, which is suggestive of pneumatosis intestinalis. And abdominal X-ray may be a quick investigations in an unstable patient to look for any viscous perforation. If you see a gas under diaphragm, it will readily say that she has perforation, and you don't need a CT, and surgeon possibly will take her immediately to theater to fix the problem rather than wasting away time. So it is prudent that one could consider doing abdominal X-ray in a sick with abdominal pain, and it is not something which one should discount. And even any big calculi also can be visualized. So abdominal X-ray still has a role, especially when someone is very unstable and you are unable to shift to CT. It's a simple test on the bedside to rule out perforation. And in this case, as you see, there was pneumatosis intestinalis, but the sensitivity is low. So then the question I would ask the panelists is there a role for abdominal ultrasound in these patients? So ultrasound may not be a great tool for anything to do with bowels, because any gaseous sort of a structure, ultrasound is not the best of the tool. But ultrasound is useful to pick up any gallbladder calculi, or it is useful to pick up any hydroelectronephrosis due to any obstructive etiology or any ureteric calculi. And ultrasound is also touted to be useful in acute appendicitis to differentiate between complicated and uncomplicated. Because there was this study which showed that in 119 patients they looked at with 32 complicated appendicitis, loss of echogenic submucosal layer, if one could see, it predicts with 100% sensitivity the complicated appendicitis and with 92% specificity. So loss of submucosal, possibly I would say you would need possibly a skilled sonographer to ascertain this, or someone who, because there can be observer intervariability with regards to this, but this is the evidence for you. But if there is a loss of echogenic submucosal, it can identify complicated appendicitis with good sensitivity and specificity. So ultrasound has bearing only in these sort of conditions for abdominal pain. Now the question is role of CT. So in this day and age, I am sure every listener hearing to this would say that they would push this patient for a CT, which is rightly the right way of doing things. So CT has a definitive role in establishing the diagnosis. So one thing the listeners need to look at is the evidence that is prevailing. So this was a study from Finland where they have looked at 74 patients more than 65 years of age presenting with abdominal symptoms, where with increasing age, there is a higher likelihood of CT to pick up specific diagnosis, and was found to be cost effective. So this was another study which came from France, done in 405 patients, in patients more than 75 years presenting with abdominal symptoms, where they showed the diagnosis accuracy or the diagnosis of the underlying condition improved from 76.8 to 85% by doing CT without wasting much time. And treatment also improved from 88.5 to 95, which means CT is the way to go for any sort of an abdominal unsettling issue to determine what may be the underlying reason. And unsuspecting abdominal disease also was picked up in 30.3% of the patients in this particular study, and 3.4% had to undergo surgery for otherwise sort of a suspecting underlying condition. So goes on to show CT has a definitive role to play in picking up the underlying diagnosis, and even unsuspecting underlying diagnosis needing some interventions to save a life or to improve the quality of life, so on and so forth. So this is the evidence we have for the value of CT in establishing diagnosis for abdominal structures. And CT is also very useful for identifying and recognizing this diverticulosis, and it is 93% sensitive for picking up diverticulosis. And to enhance the sensitivity, one could give oral contrast 2 to 3 hours prior. So oral contrast, but enema is to be avoided, because enema, barium enema is to be avoided. But one could give the gastrography as a oral contrast, or it could be given as enema. Sensitivity improves to even 99% by doing CT in diverticulosis. So this patient, this is the CT where it shows some diverticulosis with sort of an inflammatory mass tracking to the psoas as well in this patient, along with the bowel obstruction what she had. So, and then, so doing a CT with contrast, with CT angiography, is a definitive tool to recognize mesenteric ischemia. So for this patient, CT angiogram was done. We showed mesenteric ischemia. So this is a study from Canada which showed multi-detector row CT is what has an ability to pick up mesenteric ischemia with a higher sensitivity of 96% and specificity of 94%. So this patient had non-occlusive mesenteric ischemia. So which means there was no sort of a thrombus or occlusion of the mesenteric vessels. So this is just a diagrammatic representation of the blood supply of the gut, which is predominantly supplied by the superior mesenteric artery and inferior mesenteric artery. And non-occlusive mesenteric ischemia is a condition where there is no occlusion, but because of the underlying sort of a hemodynamic compromise, there is a sort of a compromise in the blood flow. But there is no occlusion, there is no mechanical obstruction of these vessels. And this constitutes 20% of the mesenteric ischemia as per the literature. So NOMI is a cause of mesenteric ischemia in 20%, but they are reversible. And it is mostly related to the hemodynamic compromise, underlying hemodynamic compromise that would have set in for whatever reason. And the risk factors for NOMI is any patient with cardiac conditions, someone with heart failure, someone who's had arrhythmia, someone who's had an AF, they can emboli and that emboli can get resolved and there may not be an occlusion of the mesenteric vessels, or there can be peripheral vascular insufficiency or peripheral vascular disease, underlying sepsis, and pancreatitis, or certain drugs have been incriminated like digoxin and alpha agonists, and someone with chronic underlying disease like someone who is on dialysis where there is extracorporeal blood flow which can compromise the mesenteric blood flow, or someone who is on cardiopulmonary bypass which can sometimes compromise your mesenteric blood flow. Any underlying condition which can compromise the mesenteric blood flow can lead to non-occlusive mesenteric ischemia, especially in elderly with an underlying cardiac condition. And more so if they're on drugs like digoxin or alpha-adrenergic agonists, any of these can be risk factors. So this patient typically has had, possibly she had diarrhea and she had hemodynamic compromise and she had a underlying diabetes along with coronary artery disease. This may have caused the mesenteric sort of a non-occlusive ischemia for this lady. And this obviously with medical therapy, they would improve. And cocaine addicts also are at a risk is what is referenced. So with regards to non-occlusive mesenteric ischemia, abdominal pain can be absent in 25% of the patient. The goals of treatment is predominantly hemodynamic stabilization is what is needed. So this diagram is put because if one has to rule out mesenteric ischemia, they have to do arteriography, mesenteric arteriography to see if there is any occlusion. Or CT angio many a times may be able to pick up, but the definitive diagnosis is by doing mesenteric arteriography to look at the occlusion. As you see here, there is occlusion of the superior mesenteric artery here. So goals of treatment is hemodynamic stabilization is the way in non-occlusive mesenteric ischemia, and correction of underlying problem. This lady has had diarrhea and possibly that also would have caused the problem. So under correcting metabolic acidosis and antibiotics to be considered because of mesenteric ischemia, there can be a gut translocation of bacteria because of the mucosal barrier breach that would have set in, and Rayleigh tube drainage to clear the sort of a gastric accumulation. So the treatment is going to be symptomatic. Anticoagulation is something one could consider prophylactically. Therapeutic anticoagulation is mainly for obstructive, but in non-occlusive, it is more focused on correcting of underlying cause and hemodynamic stabilization. So that's about the case. So just a simple overview for all the trainees to have an overview on how to approach an abdominal pain with diarrhea in an elderly, and what are the sort of pertinent investigations one should bear in mind. So thank you, everyone. So end with this beautiful quote. So try to learn something about everything, and everything about something. Thank you, Manda.